Good day. This is Saul Weingart. I am Vice President for Quality Improvement and Patient Safety at Dana-Farber Cancer Institute in Boston. My task today is to talk with you about the role that patients and families might play in partnering with clinicians and healthcare organizations to improve patient safety. As many of you know, the patient safety epidemic became an issue of public concern in the late 1990s, especially with the release of the 1999 Institute of Medicine report, To Err is Human. The report identified a number of opportunities for improvement with calls for research, education, and initiatives at the bedside. In addition to activities that improve medication safety, reduce infection, and address complexity-related errors in a number of domains, groups began to take some interest in the role that patients and families might play in driving safe care. The concept of the vigilant partner was advanced as a way to encapsulate this concept that patients are highly motivated to notice what goes on with their own care and to communicate with providers in a way that leads to safer care. Now, that approach has some obvious limitations. When patients are ill, acutely ill in particular, they may not have the wherewithal to do much at all to advance their own care. On the other hand, many patients are highly motivated and interested, and their families are deeply involved in most aspects of the care that they receive. A number of organizations have developed campaigns or other sorts of programs to educate consumers about their health care, and in particular to identify things that they might do, that is, patients or families might do, in order to make their care safer. So, for example, the U.S. Agency for Healthcare Research and Quality developed 5 steps to safer health care. This approach asked patients to ask questions if they had doubts or concerns, to keep and bring a list of all their medications when they visit the doctor or go to the hospital, to get the results of tests or procedures, to talk to their doctor about which hospital might be best for them, and to make sure that they understand what will happen if they need surgery. Similarly, the Joint Commission for Healthcare Accreditation developed something called the Speak Up campaign, which encourages patients to take an active role in both understanding and seeking to ensure the quality of their care. I think it's fair to say that not all recommendations for consumers are created equal. My colleagues and I did a study several years ago where we investigated the kinds of recommendations that organizations had put forth for consumers. Specifically, we examined 26 high-profile U.S. healthcare organizations and the consumer recommendations that they advocated. We thought, in fact, that each organization might suggest a handful of recommendations and that there would be a lot of duplication across these healthcare entities. In fact, we found that there were about 160 recommendations and that many of them left something to be desired. For example, one of the recommendations suggested that patients learn to recognize liquid medications by smell. Another one suggested that consumers asked for a copy of their hospital medication administration record, the one that nurses use to record the medications that the patients receive, and they suggested that the patients check this medication administration record, or MAR, for accuracy. Another recommendation asked patients to keep the lights on so they don't accidentally take the wrong drug. And one more recommendation suggested that patients keep people medicine separate from pet medicine. Now, I don't mean to suggest that these are not ridiculous suggestions. In fact, they're commonsensical recommendations that might provide some benefit in the right situation. But overall, when you look at the quality of the evidence that's behind the recommendation, the likely health benefit from following the recommendation, patients' likelihood of adhering to the recommendation, it turns out that the most commonly advanced recommendations are often the ones that have no particularly high scores on these criteria. In fact, when we had investigators in this study, many of whom were well-known experts in this field, they found that the most commonly advanced recommendations were not often the ones that actually had the most value. When we asked the investigators' mothers to make the same assessment, they were a little bit more generous than the investigators, but the common sense of motherhood more or less agreed with the conclusions of the experts that we have to be careful about what we recommend to our patients, that we don't want to confuse them by offering advice that is of low scientific quality, that's unlikely to make a difference, that they're unlikely to follow. I'd like now to mention two objectives for this talk. One is that I hope that by the end you will have a better sense of what is the patient's experience and understanding of medical error, at least on the basis of some of the research studies we've completed to date. And secondly, I'd like you to have a sense for what role patients and their families might play in identifying medical error and, more importantly, in preventing harm. On a conceptual level, there are several conditions that patients or families need to be present in order to prevent medical errors. First of all, they need to be able to identify the errors. Secondly, they have to be able to communicate their concerns to someone. And finally, they need to behave in a safe way. Let me go through each of those issues in a little bit more detail. First of all, can patients identify and communicate errors? We know a little bit about this from national surveys that have been performed. For example, in a study that Blendon and colleagues reported in the New England Journal of Medicine in 2002 of a national telephone survey of over 1,200 patients, 42% of those patients reported medical errors in their own or a family member's care. They found physicians responsible for most of the errors, and they were disappointed to report that few of the clinicians disclosed the error or apologized. Now, this is an important study because it does give us a clue that most consumers have some exposure or experience to medical errors. The difficulty in this case is that it's hard to know if the kinds of things patients were reporting are the same kinds of things that a health professional might consider to be an error. Perhaps patients and families have a different perspective on this. The other issue is that this was a prevalent study. It asked whether at any time in the past the respondent had become aware of an error affecting their own or a family member's care. So my colleagues and I set out to understand a little bit more about the incidence of patient-reported errors. In other words, how common in a particular period of time was it to find some new event. And what we did was we did a very simple thing. We had a research assistant go around and interview inpatients on a general medical ward in a hospital. And they asked the patient a couple of questions. Do you believe there have been any problems with your care? Do you believe you were hurt or stayed in the hospital longer than necessary? And do you believe that anybody made a mistake that affected your care during the hospitalization? Patients identified a variety of events. So, for example, one of them said, I had a PICC line, that's a intravenous catheter, put in, and I got an abscess. They took me to get surgery. I had a blood clot, and they removed part of my vein. That's a serious adverse event. My blood sugar went sky high because they did not give me my diabetes medication. That's a significant adverse event. It's not as severe as the serious one, but it's still an event that is of some concern. Patients also identified near misses or close calls. So, for example, one patient said, the doctor came in and suggested I get a flu shot. I'm allergic to it. It would kill me. Do the doctors not check patients' charts? Overall in this study, we found that events that patients reported that a team of physicians reviewed for credibility, that of these events, of these patients, about 7% experienced an adverse event in the hospital, and that about 5% of the patients experienced an event that could have been preventable. In other words, an error that resulted in an injury. Larger studies have replicated this kind of an approach, and the best of these studies is a study of 16 Massachusetts hospitals that was published by Joel Weissman and colleagues in the Annals of Internal Medicine. In this study, the investigators completed post-discharge telephone calls to over 2,500 patients. And then of those 2,500 patients, almost 1,000 of them also agreed that the investigators could obtain and review their medical record. And what happened was the researchers went through the interviews and went through the records independently and then analyzed and classified patients' reports. The important finding in this study was that there was very little overlap between the kinds of events that patients report and that are confirmed by a physician panel and the kinds of things that are found on chart review that are written in the record by clinicians and then reviewed and confirmed by the clinician panel. In fact, of the adverse events that were discovered in this study, 23% were reported by patients, 11% were identified on chart review, and only 5% were in common. So the important lesson here was that patients can identify a whole series of events of which the hospital and the caregivers may be completely unaware. It's an important finding because it tells us that patients are noticing things that organizations are not keeping track of and that might be targets for improvement. Now, how good are patients at identifying these events? It's a good question. There is a sense that some clinicians have that patients are very concerned about problems that clinicians might not see as serious. So, for example, many of the patients in the Weissman study reported pain related to the presence of an intravenous line. And this is the kind of thing that might be very concerning to a patient or a family member, but is more or less a cost of doing business, a routine event that's reported, that's part of most patients' care. So in order to follow up on this concern, an additional investigation was done of this Weissman data in a study that was led by Junya Zhu. And in this study, Dr. Zhu looked at a variety of adverse events that were reported by patients, or rather, she looked at symptoms reported by patients and what was the likelihood that the physician panel that reviewed it would confirm these events as adverse events. And it turned out that as few as 60% or as many as 94% of the events that patients reported, a physician panel would say, yes, this event did sound like an adverse event. It was credible. It made sense. The response of the clinicians and of the hospital were all consistent with that. So there is a sense that while patients report all kinds of experiences, if the patient thought that they had some sort of an error or an injury due to care, that is a reasonably likely that is reasonably likely to be true, or at least something that a panel of physicians would find highly credible. Now, what about in other settings? Dr. Tejal Gandhi and her colleagues at Brigham and Women's Hospital performed a study that was published in the New England Journal in 2003 that looked at adverse drug events. These are injuries due to medications that affected patients in 4 ambulatory practices, again in Massachusetts. They performed chart reviews and telephone interviews, much like the Weissman study, and a physician panel classified the reports. And the thing that's important there is that again, patient reports and chart reviews, the former reported by patients, the latter documented by healthcare professionals, both identified adverse drug events, but again, there was very little overlap between these methods. In fact, patients again represent an important reservoir of information about patient safety, and if we fail to take account of that information, we may miss an important reservoir of data. Another thing to bear in mind is that patient surveys are much more efficient ways to collect information than conducting chart reviews. So these patient-reported events have a lot of opportunity for us in order to identify and examine and understand adverse events that affect patients. Next, I'd like to talk a bit about the role that patients might play as active partners in preventing safety events by behaving in a way that promotes safe care. Now, there are some limitations to this, clearly. I have a cartoon here which shows a surgeon asking a patient if they've ever assisted in an operation before, and the caption is, "More proof of the alarming shortage of qualified medical personnel." Clearly, patients cannot do everything. They cannot perform surgery, certainly not on themselves, but there may be some things that they can do. To that point, the Kaiser Family Foundation, together with the Harvard School of Public Health, has produced a series of surveys over the years in which they asked patients about safety-oriented behaviors. For example, they asked patients if they've checked the medication that a pharmacist gave them with the prescription that the doctor wrote, whether they called to check on the results of a medical test that they had performed, whether the patient brought a list of all their medications to the doctor's office, whether they brought a friend or relative along, or whether they told a doctor, nurse, or surgeon about drug allergies when the doctor, nurse, or surgeon didn't ask. So these are all safety-oriented behaviors that rely on the patient to check or inform or advocate for themselves. In the Kaiser surveys performed in 2004, 6, and 8, one can see that patients and families are more likely to perform certain behaviors than others. So, for example, it's very common for patients to check the medications against a prescription. It's much less common for them to speak up about their own drug allergies when no one asks them. There does seem to be a bit of a trend toward bringing more medications to the doctor's office and bringing along a friend or relative to help ask questions and understand what the doctor told you. So there's some opportunities for improvement in these large studies, or in these large surveys rather. But again, it's hard to know whether these behaviors are done all the time or just once in a while, since the survey again asks about prevalence. To get a more granular and detailed sense of this issue, several investigators have interviewed patients about error prevention behavior that they used themselves, particularly during a recent hospitalization or episode of care. So, for example, in an interview study by Waterman that was published in 2003, that was published in 2006, performed in 2003, of over 2,000 patients at 11 U.S. hospitals, 91% of patients said that they were very comfortable asking about the purpose of a medication that they received. In contrast, only 46% were comfortable asking medical personnel if they had washed their hands before seeing or treating them. So in this study, there were a variety of different safety-oriented behaviors that were performed, asking a nurse to confirm the patient's identity, having a patient or family member watch for errors, helping healthcare staff to mark a surgical site. Comfort levels were reasonably high for many of these behaviors. 70, 80, 90% of patients said that they were very comfortable. But when the investigators asked if the particular behavior was actually used, in other words, did the patient take action to implement these behaviors in the setting of their recent hospitalization, there was a significant voltage drop. So, for example, 84% of patients said they were very comfortable asking a nurse to confirm the patient's identity, but only 38% actually did that. 72% of patients said they would be very comfortable, or said they were very comfortable helping a healthcare staff mark the surgical site, but only 17% did that. So the voltage drop is a little bit difficult to interpret because it included the difference between intention and action. We know about that from social psychology. There's a gap between intention and action, but it also may have reflected a lack of opportunity. You're not going to mark a surgical site if you have no surgery to be performed. So I think the lesson there, which is a lesson we've seen from other studies, is that patients express a lot of comfort and interest in performing safety-related behaviors, but they don't always act for a variety of reasons. So there are a number of factors that get in the way of patients taking action, and a number of things that affect the likelihood that they might do so. So, for example, the gravity of the perceived threat is something that motivates patients to act in a safety-oriented way. The perception that the harm or potential harm is preventable is something that increases the likelihood of acting. The perceived effectiveness of the action, in other words, of the patient's action, in making a difference. Patients' perception that there may be consequences of speaking up. In other words, if they speak up in a way that challenges health professionals, perhaps the doctor or nurse won't think that the patient is a good patient, or will avoid them, or will be wary of them. So it may affect the relationship, and they worry about that. That might decrease the likelihood of speaking up or taking action on their own. It turns out that patients have a sense of self-efficacy. Many people feel more empowered than others and feel that their own behavior can make a difference. And folks who have more self-efficacy are more likely to take action to keep themselves safe in the hospital. This, of course, raises the question about what we can do to promote self-efficacy. Finally, and most importantly, patients and family members' likelihood of acting in a way to keep the patient safe in the hospital depends deeply on the kinds of instructions and expectations that staff members present to the patient. In other words, if a physician says to the patient, "I want you to keep me informed of anything that you think is out of the ordinary or concerning or worrisome to you, please let me know," the patient is much more likely to do that. Or if a nurse wears a button that says, "Please ask me if I've washed my hands," indeed the patient or family member is much more likely to engage with that healthcare professional and to communicate with them about any concerns they have about hand washing. So indeed it has a lot to do with not only attributes of the patient, the perceived risk, but also the degree to which the behavior is invited and welcomed. All this then leads to the question, how do we promote engagement? If we know that patients and families can identify risky situations and potential harm, and we know that many of them have some willingness to act. In fact, many patients are willing to do something about a perceived threat. How do we build an environment in which this can work effectively? And what I'd like to do is to describe several examples of interventions that organizations have performed or programs they've created that seem to build an effective partnership with patients. I'm going to give a number of examples from my own organization to illustrate some of these opportunities. I'm going to start by talking about medication reconciliation, which is a Joint Commission requirement and a patient safety best practice. Medication reconciliation, according to the Joint Commission, is a process by which we accurately and completely reconcile medications across the continuum of care. The way this plays out is that healthcare professionals need to make sure that the medications that they think the patient is taking is the same as the medications that the patient thinks they're taking for ambulatory patients. In the inpatient setting, we want to make sure that the inpatient drugs reflect the drugs that the patient should be on, and that at transitions from home to hospital, changes within the hospital, discharge to home from the hospital, that we take account of any changes that are made so that the patient doesn't end up taking, for example, 2 similar antihypertensive medications when only one is intended. At Dana-Farber, we investigated the quality of our medication lists. We have a fancy electronic system that we share with our partners in primary care and in other areas of specialty care. And we set out to find out in a small group of patients how accurate those medication lists are in the electronic medical record. So in a series of over 300 patients taking more than 2,000 drugs, we asked the patients to look at the list and to correct the drugs that were incorrect, to identify medications that were on the list that they no longer took. And if there was a medication that was missing from the list altogether, we asked them to tell about that as well. And it turned out in our very fancy state-of-the-art system, the chance that the medication list, that any medication on the list was correct was about 50-50. A small number of the drugs had the wrong dose or frequency listed, and then the remaining were either drugs they were no longer taking or drugs that they were taking but hadn't been yet updated. Some of these medications were quite scary. For example, some of the missing drugs included anticoagulants, oral chemotherapies, seizure medications, hormonal therapies. Some of the corrected doses included anti-rejection medications, again, seizure medications, anticoagulants, pain medications. So the hazard associated with failing to update the medication list were quite significant. We ended up doing a fairly simple thing. We asked the clinic assistants in our units to print out the medication list from the medical record, to present it to the patient, to give them a nice note from me which asked them to update it, and then after the patient had updated the list, showed it to the provider, who then signed off on it or made any additional corrections, we had a pharmacist enter that information into the medical record. So this was an opportunity to partner with patients in a very easy way. We didn't rely on the patients. The providers were ultimately responsible for ensuring that the lists were updated and corrected and needed to sign off on the changes the patient made. But at the same time, this made a very dramatic difference in the accuracy of our medication lists. When we did a follow-up evaluation of about 100 patients, we found that patients who had usual care, that is, who didn't go through the medication reconciliation process, only about 2% of the medication lists were updated. On the other hand, when we invited patients to work with us to update these lists, the rate was 90%. So this was a dramatic improvement. Organizations across the country have experimented with other kinds of interventions and implemented many of them on a routine basis. One common intervention, which seems quite promising, is something called Condition Help, or Code H. This is a a program that allows patients and families to call for medical assistance for an inpatient typically, or an outpatient if that is set up in the organization. The idea here is that when someone has a sick relative in the hospital, it's possible that a family member might notice a slight change in status or some otherwise unrecognized issue. And even in the hospital, it's often difficult to call an alarm or to rally the troops. Doctors and nurses and others are often deployed throughout the organization. But if you can call a condition help or a code H, it is equivalent to a medical emergency response and brings various providers to the bedside in order to find out if the patient indeed is having some trouble that the family or friend has identified, or the patient themselves. And so this has been a very effective program. It's been implemented initially in a number of children's hospitals, but is now in place in many other settings as well. In the early days, there was some concern that patients would inappropriately call a code, but the early experience has shown that, in fact, patients and families are quite responsible about calling when it's appropriate to do so. Another initiative which has some promise is the idea of allowing and facilitating incident reporting about patient safety events by patients and families. Several groups have developed such reporting that is tailored to the needs of patients and families, including groups in Sweden and the Netherlands and in the United States. The Danish Patient Safety Agency was one of the very first organizations that developed such a reporting scheme. Other organizations, including our own, have begun to do this, although it does require a lot of education and outreach in order to make these kind of reporting systems available to patients and to educate them about how they might access and use them. Next, I'd like to talk about a promising intervention using technology. This intervention was developed at Beth Israel Deaconess Medical Center in Boston and uses a patient portal called PatientSite. Portals are web pages websites that allow patients to access information about themselves. Some portals offer information about the patient's problem list that the doctor keeps, or the medication list, or laboratory results, or radiology reports, and so forth. Some of them allow for secure electronic messaging between the patient and the provider or their practice. The portal at Beth Israel is called PatientSite and has many features that are available to a patient, including the medication list and laboratory results and secure messaging. Now, we conducted a project that was designed to improve communication between providers and their patients. And the reason we wanted to create this intervention was that we learned in a previous study, the Gandhi study that I referred to earlier, that preventable adverse drug events, that is, injuries due to medications that are preventable in ambulatory care, were more often related to communication failures than to anything else. In fact, we found that more than a quarter of the preventable adverse drug events occurred when patients failed to inform their providers that they were having some symptom related to their medications. Erectile dysfunction on antidepressant medications, dizziness on blood pressure medications, that sort of thing. In addition, we found that more than 40% of patients, more than 40% of the preventable adverse drug events occurred when the physicians failed to act on information that the patient relayed. And that may have occurred because they didn't appreciate the significance, or they wanted to give it a little more time, or for some other reason. So if we could find a way to improve communication by getting information from patients about worrisome symptoms to the provider and providing a mechanism for the provider to ask the patient about symptoms they were experiencing, then that communication might reduce the likelihood of experiencing an adverse drug event, or at least mitigate the severity and duration. That was often a problem, where patients would experience problems for several months before their next appointment, when they'd finally bring it to the clinician's attention. So we did a very simple thing. We created a program that would scan for new prescriptions, and then 10 days after the patient received a new prescription or a change in an old prescription, it would fire a message off to the patient in patient site asking the patient if they had filled their prescription, if they'd filled it, if they had any problem with it. So in that first year that we turned this on, we spent 5,000 messages out to patients of this one this one set of primary care practices in different locations. And over 500 patients responded, and of those that responded, a third said that the medication hadn't been filled, and typically that was because they had an existing supply of medication that they were using up. But there were several times when patients weren't able to get the medications filled because they required prior authorization, or the copayment was too expensive, or the prescription had never been received by the pharmacy, for example. And about half the patients reported that there was some kind of problem that they encountered, either a symptom related to the medication or some other issue that got in the way of them taking the medication correctly. They were worried about a potential interaction, or they took the first dose and it made them feel funny. So what we found was that by providing this opportunity to communicate, it resulted in a lot of back and forth between the patient and provider. It often went in ways that we didn't anticipate. In other words, people used the medium, used the opportunity to communicate, to talk about a variety of things that were typically related to the drug, but not necessarily. So we think that this has some opportunity, some potential to improve patient empowerment, to reduce the amount of time it takes to follow up on potential communication issues with respect to drugs, and may ultimately prevent errors and harm. Now, I'd like to tell you a story that's related to that. As I mentioned earlier, the site includes the capability for patients to look up their medication list, their problem list, their drugs, and their radiology reports. I was on call one night, and a patient called me up. He was covering for the practice, and the patient indicated that they had had headaches for a few months, and these were new headaches. This is a man in his 50s who had no other previous medical problems, and he'd spoken with his doctor about this, and the doctor said, well, it's probably nothing, but new headaches in an adult are something that we might worry about. It could be a tension headache. It's unlikely to be a migraine. It wasn't throbbing. It didn't seem to be positional. There were no neurological symptoms at the time, but he said we ought to check an MRI as a precautionary measure. The patient agreed, had the MRI scheduled and completed, and called to tell me that he'd looked up the results in the computer. It appeared that his doctor was away, and he had gotten in touch with me as the on-call provider. He said that the report in the computer said that he might have a brain tumor. I said that that was concerning. I could understand why he called, and I said that I hoped the report said that it was a meningioma, and he said in fact it was, and he had Googled it, so he understood that a meningioma was a benign tumor. It probably had been there for a while, it may have grown, it would likely need to be addressed, but he said there was some fine print in the report that he didn't quite understand. He said that there was some cerebral edema and midline shift and something about early herniation.
I confirmed with him that those were pretty serious reports, that the meningioma had caused swelling, effacement of some of the structures. It sounded as if it was pushing some of the brain tissue from one side to the other and perhaps down in the skull. But I said, we don't treat scans, we treat people. How are you? I feel terrible, he said. The headache's getting worse. It's worse when I lay down. I started vomiting, and so forth. So he ended up going to the hospital right away, being evaluated, treated with steroids, and ultimately had a resection. And he did very, very well. But he is our N=1 poster child of the role that an empowered patient can play in a modern healthcare system. He identified the issue, he brought it to my attention, and he behaved in a very safety-oriented way, I think it's fair to say. Now, this case also poses a question. This was a success in terms of patient engagement, but it was clearly a failure in terms of the infrastructure and systems we had in place to ensure safe care. There were a number of handoff issues and communication problems between the radiologist and their team and the medical group that was caring for the patient. And I'm pleased to say that those issues have been dramatically improved. But if it weren't for an empowered patient, I'm not sure where we would be. I afterwards asked him about the case and how he managed to stay so calm through it all. And he told me that he had been a health administrator for many years and that he'd seen worse. Next, I'd like to talk about teamwork training. Teamwork training has been identified as a potentially very important approach to patient safety in hospitals. Teamwork training developed initially in the aviation industry after a number of significant collisions in the 1970s, including the Tenerife disaster, the largest disaster in aviation history, in which two large passenger planes collided, primarily due to problems with communication in the cockpit and with the tower. Teamwork training in healthcare has begun to be disseminated widely, in part through the efforts of the U.S. Agency for Healthcare Research and Quality and their Team STEPS program. It's been piloted in a variety of organizations and in a variety of settings, including the intensive care unit, the operating room, the emergency department, and labor and delivery. And there are a couple of key principles that have been advocated, making sure that junior members of the team assert themselves appropriately, making sure that there's a briefing before and after a certain shift so that all the members of the team know what's the plan and what happened, can learn from experience. There's a concept called closed-loop communication, in which we make sure that the message we send is the message that was received. It's similar to what happens when you order Chinese food over the telephone and someone at the other end repeats the order back at you. And then there's a concept called situational awareness, which involves keeping an open mind about the entire situation that one is involved in, rather than getting too narrowly focused. So, for example, in a cardiac arrest, there's a risk that everyone focuses on the EKG monitor rather than on the airway, for example. So at Dana-Farber, we decided that we would try to implement a team training program that was focused on patients. We thought that it was important for providers to work together as a team, but in a cancer setting, it's very important for multiple providers to work together with patients and families, and for patients and families to see themselves as part of the team and to take on appropriate responsibilities for follow-up, getting their laboratory tests done, taking their medications, and so forth. So we developed a program where we developed this concept of the team, the basketball team, the pit crew, the soccer team, the swim team, and we attempted to roll this out to our patients, and it turned out to be a huge flop. So we went to our Patient and Family Advisory Council and we said this program was a flop. Nobody showed up, and even though we offered really good food. And the response we had from our Patient and Family Advisory Council was as follows. They said, this is a really interesting and important idea, and we do believe that teamwork is key. But you need to rethink the way that you're bringing this forward. It can't be a doctoral level course that requires intensive study. It has to be a campaign. It has to be something that's simple, easy to understand, and absorb. You can't expect patients to go to a classroom setting for instruction after they've been stuck in the hospital all day or getting their treatment. You have to go to the bedside, and you have to focus on hazards rather than skills. Rather than focusing on concepts that seem rather abstract, like situational awareness, we need to think about the patient who gets the wrong medication, or there's some last-minute change in their drug, or hand hygiene. So we ended up working with our Patient Family Advisory Council and some patient volunteers to revise the campaign and the approach. We called it the You Can campaign. You can check your medicines. You can ask if the providers wash their hands. You can notify us of any last-minute changes. And the goal was to empower without creating an obligation. The obligation for care relies entirely on healthcare providers, but we can empower patients to be a source of resilience, to help us do our job properly, to be vigilant partners. And the volunteers who worked with us to develop the program brought it to the bedside. They visited patients in the infusion area, in the waiting areas. They handed out materials. They role-played how they might use some of this information, and more importantly, they made an assessment with the patient about how much or how little of this information they were ready to absorb. The evaluation of the program showed that we reached over 1,000 people just in the first few months of the program, and of those who were aware that we were doing it, almost half said that it changed what they did and the way that they behaved. So we think that this is another very interesting and promising opportunity. This goes to the role of advisory councils. Dana-Farber has had adult and pediatric advisory councils for more than a decade, and they include patients and family members who work with us and give us advice about a variety of things, including food in the cafeteria, artwork on the walls, but they also have an important role to play in quality and safety. Patients sit on our board-level quality committee and on our patient safety committee, where we discuss very high-risk situations, critical events, and regulatory and reporting issues. They've also helped us to develop initiatives around disclosure and apology and pathways that allow our patients to get through the emergency room quickly, so that immune-compromised patients are fast-tracked through and don't have to sit in a waiting area with other folks who may have potentially infectious diseases, for example. Patients helped us to design our new building in a way that made it accessible and welcoming. So what can providers do, and what can healthcare organizations do to drive patient engagement? They can do a variety of things, and I've spoken about these earlier. They can educate through brochures, posters, educational materials. They can encourage patients to report problems, errors, or, quote, negative events, unquote. Different patient groups may have different ways of understanding or responding to safety events, and it's important to figure out what kinds of terms work in your environment. We can empower patients through things like Condition H or Code Help. We can engage patients through programs like medication reconciliation or teamwork training. We can offer them teamwork. We can offer them technology, such as portals that allow them to investigate their own health care and to communicate with us more effectively. And then finally, we can provide teamwork tools that allow patients to to have access to some of the same kinds of strategies that high-performance cockpit crews or ICU teams or operating room teams have. And our experience, at least at Dana-Farber, is that some, but not all patients, will find these tools helpful. They'll use the tools, or at least they'll perceive that the environment in the organization is such that we welcome their engagement, participation, their advice, and their input. The role of patients and families is not yet fully worked out in healthcare, I think it's fair to say. There are a number of questions that need to be addressed with respect to patient engagement and patient safety. How much can and should we rely on patients to ensure their own safe care? Does patient participation signal a failure of our systems to prevent or trap errors? Can we customize the approach for different patients with different capabilities? And finally, what safety behaviors for patients and their families hold the most promise? These are all important and challenging questions, and I hope that you will take some of these on, think about them seriously, how they might apply in your own organization, and help us to design a system where we can partner with patients in a way that creates opportunities for participation, that takes advantage of the resilience that patients and families represent, but that doesn't shift the burden of responsibility from healthcare providers to patients. Thank you very much for your time. Best of luck.